pleasure of having our talking by Dr. Keir. Dr. Keir is actually a co-host, co-director of our Calgary program. She has special training and interest in congenital heart disease as well as aortopathy. And she's going to talk about a topic today that is an important topic that we don't talk about enough. And I think a lot of people would like answer to this. I know I would. I was actually quite excited about this, to be honest, because it doesn't get enough discussion, and patients ask about it a lot. So with that, I will pass it off to Dr. Keir.
Perfect. Okay. So thanks, Scott. Unfortunately, I think there's less answers than questions at the end of this, but we'll go through it. So what are the objectives? So what is the rationale for patient education about exercise? So really just what Scott had just mentioned, or Dr. McClure had mentioned, that this is a really important topic to patients. And so why do we need to discuss this? What is the evidence for exercise with aortic disease? So what is the evidence base that we're using for recommendations? What are the recommendations pre and post aortic dissection? And as a warning, they're not particularly robust. And then knowledge gaps. And I left some time at the end for really kind of brainstorming discussion, because I think it's important as a group to figure out how we approach this when we're talking about patients. And I'll show you some evidence as to why kind of cohesive recommendations and consistent recommendations are important to patients. So hopefully we'll leave some time at the end for thoughts on, how we can do this better. So what about our local data? So why is discussing exercise important? So this is not aortopathy data. I'll show some aortopathy data later. But we did 9 research priority setting focus groups with young adults with congenital heart disease in Calgary. And the number 1 rated research priority was development of individual exercise prescriptions and creation and evaluation of physical activity groups. So patients with rare diseases, especially ones that are cardiac and there is possibly a threat to exercise or a concern with exercise, this is really top of mind for these patients. And also there's a need for kind of community for these patients, because they feel quite isolated from their peers. If you're the 25-year-old guy with Marfan syndrome and all of your friends are going to play basketball, what do you do? So I think that it's top of mind for patients. And so it is an important topic for us to be addressing. So these are some comments. Sorry, I'm just going to move the visual box there. So these are some comments from patients in the groups. So the first one, and these are both patients with coarctation, so not heritable aortopathy, but a significant aortic disease. So they both said, the first one said, with my condition, I can't do heavy weightlifting, and that's been hard. I just found out this year. I live on a farm. So this is a teenager who is 16. So when I was doing it before and I was having chest pains, that's when they told me. It would have been helpful to know that earlier. So I think that this really highlights the importance of giving patients these recommendations early, so they know what their limitations are, and then also helping them kind of manage it doing their day-to-day life. The next one is another patient with coarctation who was in his 30s. So he said, there was a learning curve of learning my limitations. I was working construction and my cardiologist told me not to do that because it was too physical. So now I work at the airport. I found it weird. Be physically active, but don't be a construction worker. So I think this is also kind of highlighting the fact that these patients are really looking for specificity. And so one of the things that came out from these groups was that a lot of our conversation around physical activity focuses on things that they cannot do. And so that leaves a lot of people thinking, well, if I can't do this, I can't do this. What can I do? Can I do any physical activity at all? And it leads to real confusion. The other reason is, why should physicians with expertise in HTAD, so surgeons, physiotherapists, vascular surgeons, cardiologists, so why should we discuss exercise with patients? So kind of why is it on us? And I think one of the things we really found through these focus groups was that there was, for people with rare diseases, there is a large distrust of healthcare providers that are not specialized in that area of expertise. So these are patients talking about their experiences with non-congenital physicians or non-aortopathy physicians. So I was in the hospital a lot and no one detected my heart condition. You know, you have a heart murmur and symptoms, no, okay, on your way. I feel like I fell through a crack and I attribute it to complacency. And so by the time these patients get to us or get to the Calgary Aortic program and are diagnosed with their aortic disease and are being followed, they often had a long road to diagnosis. And oftentimes that long road to diagnosis can really lead to kind of mistrust in the system, because when you have a rare disease, it takes a long time for people to get there, right? The other one I thought was interesting was non-congenital physicians or non-aortopathy physicians either ask all these questions about my heart when I'm there for a sore throat, or they don't want to touch me. There's no in between. So I think there's an idea for these patients that they're an oddity, but also that their cases are kind of very rare and also very difficult to manage. And, you know, you'll see one of these in your career comment. And so patients do internalize this. And so I think it really highlights the importance of having these conversations with our patients, because when they finally get to people that they do consider to be experts in their condition, there's distrust of other healthcare professionals, but a lot of trust in healthcare professionals that focus on their condition. And so they really want to know what are the recommendations from my specialist. So the only study of specifically Marfan, Louise Dietz, and vascular Ehlers-Danlos patients and their thoughts on physical activity was done in Norway. So this was 36 patients, and they interviewed them about the restrictions that they've been given, about their thoughts on physical exercise, and this is kind of the paradigm that they came up with. So you can see on the left is all of the medical things or medical factors that play into their physical activity and exercise recommendation. So often these patients have other challenges, not specifically just their aortic disease. So hypermobility, joint issues, scoliosis, hypertonia, and also ocular problems for patients with Marfan syndrome, and chronic pain and fatigue. So all of these things are barriers to doing physical activity. And then also the psychological symptoms. So body image, feeling different, fear of aortic dissection, etc. And then there are all the psychosocial aspects. And I think what's important is really coping strategies. Exercise possibilities, social network, and also, you know, what their physical restrictions are, but also what can they do. So these were kind of all the things that patients with aortopathy thought about before doing physical activity. And so I think when you look at this, you can see the number of factors that go into it compared to the average person who's coming up with an exercise plan. And so the other themes they identified were a real frustration and grief at the time of diagnosis. So again, most of these patients were identified in early adulthood or in their teens. And so it really is a change in your life paradigm. So your idea of who you are, your idea of how long you're going to live, of what you can do, what you can't. And there's a grief process in dealing with that diagnosis. Again, all of these people said that the recommendations focused on restrictions instead of possibilities. So being told you can't do this, you can't do this, you can't do this, but not really being told what they should be doing or what they could be doing. And that led to a lot of confusion. The other thing was contradictory advice, led to confusion and fear of exercise. So, you know, and this was even small contradictory advice. So, you know, in a few examples, they said, well, you know, my surgeon said don't lift over 15 kilos and my cardiologist said don't lift over 10 kilos. And so really a small difference like that made a big difference to the patients, because they felt like, well, not everybody's on the same page. It's not clear what the recommendations are. And so that led to confusion and fear of exercise. So consistency was really quite important. And then I think this last point was probably the most important. So when they interviewed these 30-some patients and they asked them about their exercise, so 1/3 were in denial. And so they just ignored all the activity restrictions and did what they were doing before. So heavy exercise, isometric lifting that they weren't supposed to do. 1/3 avoided all exercise out of fear after these conversations. So they stopped exercising completely. And 1/3 tried to work within those boundaries. So these were all patients with heritable aortic disease who had conversations with specialized providers about exercise. And I think that's important because essentially our conversations were unsuccessful in 2/3 of the cases. So, you know, only 1/3 of patients, took that information and followed the recommendations, and 2/3 either just ignored it and did too much because of fear and grief. And then another third were too afraid to exercise at all. So I think that this really kind of highlights that we're not doing a great job with this, right? And, how do we do better? Because 1/3 of people following recommendations is not ideal, right? So this is a quote from a patient with coarctation in Calgary. So this is a 17-year-old. So he says, I want to go to college hockey and I need to get bigger, which means lifting heavy weights. I'm not going to lie, I still do it. I'm going to get bigger, but it's going to take a bit more time. So I think there really is a disconnect between what we're telling patients and what patients do. And that's normal in kind of all things. But at the same time, I think we really have to recognize that the communication of how we do this is really important, because it makes a difference as to whether patients follow through or not. So what are the activity restrictions in HTAD? So I'm going to go through a little bit of the evidence, but this is kind of the classic description based on increasing static component. So on this axis here, you can see that the exercises at the top are the ones with the highest static component or isometric activity. I think what's really interesting with this is that anything with a star or a cross next to it are indicative of high risk of body contact or heavy body contact. And so all of those things are restricted in patients with heritable aortopathy, and we'll talk about the recommendations. And then these ones are increasing dynamic component or aerobic activity, and so it's based on your VO2 max. And again, so if we're saying that this is the safe area and I'm counseling a 16-year-old, or you guys are counseling a 16-year-old, it's kind of difficult to say to a 16-year-old, well, you can't play basketball with your friends, you can't run, but you can play billiards or bowl or riflery, right? So I think that we have to kind of rethink this a bit. And also, what is the evidence for telling patients that they need to stay in this kind of narrow box here? And what is the real risk of activity, and the risk of inactivity is important as well. So just kind of remembering this table, because the importance for the recommendation is increasing the static component and then the dynamic component, but also really looking at how many activities are outside the window, right? So this is a real change in life for a lot of young people. So what is the evidence for exercise, and what does it do to the aorta and blood pressure? So this is a review, and they brought together all of the exercise physiology data. And so even just doing hand grip, so they did maximal hand grip for 1 minute. So blood pressure, systolic increased by 50 millimeters of mercury, and diastolic increases by 30 millimeters of mercury. And then if you do hand grip to only 30% maximal strength, systolic blood pressure increases by 20 to 30, and diastolic blood pressure increases by 10 to 20 millimeters of mercury. So for somebody that we're trying to do really strict blood pressure control, this shows that even minimal activities, so lifting groceries, carrying a heavy bag, can have a significant impact on blood pressure. What we don't know is, what does this do in the long term, right? So, the really heavy lifting versus just minimal activities of daily living. So what about actual weightlifting? So if you're doing a biceps curl, so heavy weightlifting, and this is 90% of max lift. And I think since I've been doing aortopathy, dealing with young men, I've said max lift more in my entire life than I ever expected to. But max lift to exhaustion, so that means lifting the heaviest thing you can, as many repetitions, and it was usually, I think, 2 to 3, causes the blood pressure to increase significantly in a short period of time. And that shear stress on the aorta and the increase in blood pressure is something that we're really concerned about. So when doing this, a normotensive individual, so they said 130/80, within a few lifts of this really heavy weightlifting, even if they tried to prevent Valsalva. So that's one of the things, is that we often say, as long as you're not doing a Valsalva, that's okay. But even without Valsalva and able to breathe through it normally, their blood pressure increased to 230/165. And so I think most of us would be alarmed by that in a patient with significant aortic disease. And then a similar increase in BP was observed with 40% max weight with repetitions to exhaustion. So even if you lift less weight, if you're doing reps to the point where you're really exhausted and you can't do one more, then you're still having a significant increase in blood pressure. So we often tell people to lift lighter weights and to do lots of repetitions, but it should be that you should do enough repetitions that you still have lots of room to go at the end. And then also Valsalva, straining, increased blood pressure even further. So we know that even normal activities increase your systolic and diastolic blood pressure. Dedicated weightlifting lifts it or increases it even more significantly. But what about the long-term data? So what does this actually do for patients with any disease or aortic disease? So the only data on this is looking at the effect of exercise on normal aortas. And so this was a meta-analysis of aortic measurements in almost 6,000 elite athletes. So they were all competing at national, international level, including collegiate athletes, and they compared them to controls. And so the mean aortic root diameter at the sinus of Valsalva is 3.2 millimeters larger in athletes than in non-athletic controls. And the aortic root size, what at the annulus was 1.6 greater in athletes than controls. So there is an increase in people that are doing heavy physical activity regularly, but it's actually relatively minimal. So the kind of take home from this is that if you have significant dilation more than 2.5 z-score 2.5 above normal or 2 standard deviations, that is usually pathologic. So we get a lot of referrals for young people that they say, oh, their aorta is 5 millimeters bigger than it should be, but they do heavy weightlifting, or but they do a lot of exercise, and so that's probably it, right? But the truth is that when you look at large groups, that actually really doesn't explain it. The interesting bit was that aortic valve annulus in endurance athletes was actually greater than that in controls that were doing, than strength trained athletes. So the increase in endurance athletes was 2.2 millimeters at the aortic valve annulus, and in strength trained athletes, so people doing heavy weightlifting and isometric activity, it was only 1.5 millimeters greater. So that thought that doing long-term heavy isometric exercise is worse than long-term dynamic exercise with high VO2 max is maybe not really borne out by the data. But I think that the take-home message from this is that if you have significant dilation, it's generally pathologic. You can't explain it by CrossFit. Okay. So what about aerobic exercise? So what does that do to your blood pressure? And what does that do to your overall fitness? So walking briskly 5 kilometers per hour is about, and it's based on METs, so about 3 METs. It increases your blood pressure. If you're average at 120, it rises between 146 and 160. So no significant rise there. And the calculation for this is that for each MET, your systolic blood pressure increases about 8 to 12 millimeters of mercury. So when you're jogging at 6 minutes per kilometer, or this is a 10-minute mile, you're doing 10 METs, and your blood pressure rises at rest from normal at rest to between 200 and 240 millimeters of mercury. So, the first number, walking briskly, most of us would be fine with this in a patient that's had aortic surgery or that has HCAD. But when we start to talk about more higher dynamic exercise, are we comfortable with this? And is this recommended, right? To have a blood pressure that might be 240 millimeters of mercury with exertion. So the other thing that's important is, what is the trade-off? So people who jog or exercise, regular aerobic exercise, have an overall blood pressure reduction of 3 to 8 millimeters of mercury. So, in daily life, if we reduce your blood pressure by 3 to 8 millimeters of mercury all the time versus that brief increase with exercise, what's the trade-off? So is that actually better? And the truth is, we don't really know, right, in humans. So the only data is in the Marfan mouse. And I really love to think about mice on treadmills and measuring the amount of exercise that mice are doing. But there's been 2 recent studies in the last few years looking at the pathology of exercise and what it does to aortic remodeling in patients with heritable aortopathy. So if you look at the kind of top left here, this is a sedentary or couch potato Marfan mouse where they didn't put a treadmill or a wheel in their cage, and they didn't let them exercise. And then this is on the bottom right is Marfan with forced exercise. And the forced exercise was 30 minutes per day, 5 minutes per week. And the average VO2 max was 55%. So this is in kind of the brisk walking to light jog area. And this one here on the bottom left was Marfan with voluntary exercise. So they didn't force them to exercise, but they put a wheel in their cage. And so what they found was that this group, the forced exercise, had actually a significant improvement in elastin fiber organization and fragmentation. And both forced and voluntary aerobic exercise increased aortic wall strength and reduced aortic dimensions when compared to sedentary mice. So even though we think that this level of exertion increases your blood pressure, in the long term, is it actually beneficial for remodeling of aortic tissues? And so there was a second mouse model that was a really similar study, and they found the exact same thing. So we don't have this data in humans, but at least in a similar model, it looks like the exercise is actually beneficial. And this was dynamic aerobic exercise, not isometric exercise. So what are we really worried about, right? And I think this is the thing that we all have in the back of our mind when we're talking to these young people about physical exertion. So we're all worried that they're going to have sudden cardiac death or a dissection with exercise. So what is the risk of cardiac death with exertion in heritable aortopathy? And the truth is we don't know. But if you look at the US National Registry of Sudden Death in Athletes under 40 years of age, so this records anybody and it's mortality registry where they look at anybody who died during or after physical exertion who's under 40. And in the 2,588 deaths in the registry, only 25 were due to aortic dissection, so less than 1%, and 19 were due to aortic stenosis. And the majority of these were patients with an undiagnosed bicuspid aortic valve with moderate to severe stenosis. Of those patients that died doing physical activity, sports associated with cardiac death were mostly basketball and football, baseball, and then weightlifting. And I think importantly, 33 out of 44 deaths were during practice or competition. So this is so afterwards or during the actual competition. And the other bit is that a third had their disease identified, but continued to compete. So these were patients that knew they had aortic disease and either were not appropriately counseled or counseled that they could continue or were counseled against exercise and continued to compete. So I think this tells you about the values of patients as well, in that when we tell patients that we don't recommend that you do this level of exercise, they're going to make their own decision, right? And for some, the value of doing these physical activities in their lives is higher than the risk of death. And the actual overall risk of death is relatively low from physical activity. So what are the recommendations? So this comes from the competitive athletes recommendation from the ACC, the Braverman group, and they're mostly level of evidence C, so very little evidence for this, mostly consensus recommendation. And again, they're mostly focused on what patients can't do or what patients shouldn't do, and not necessarily focused on what patients should. So the recommendations are for bicuspid aortic valve, if your Z score is less than 2 and your stenosis is not moderate or severe, you can participate in all competitive athletics. So, you can be in the NFL, essentially. If your aortic dimension is 43 to 45, you can only participate in low intensity, low static exertion with low risk of body contact. So there's a real dichotomy there that if you're 40 millimeters and you have a bicuspid valve giver and you can play in the NFL, and if you're 43 millimeters, then you have to do riflery and golf, right? So there's a big difference, and you can imagine how difficult that is for patients to kind of conceptualize, right? In Marfan syndrome, So they recommend that you can participate in low to moderate static or low dynamic exertion if your aortic dimension is less than 40 millimeters. And then again, what does that mean for patients with an aortic root dimension of 41, 42, 43? And we have so many of these patients that we're following. So does that mean they shouldn't participate in any exertion, or only, again, the golf and riflery and bowling, right? And that's going to be a difficult sell. Heritable thoracic aortic disorder. So this was not Marfan syndrome. This is Louis-Dietz, vascular Ehlers-Danlos, the ACTA2 mutations. So they had said no competitive sports with intense physical exertion or risk of bodily contact. So again, what does that mean, right? I mean, I think risk of bodily contact we can all conceptualize, but intense physical exertion. And then again, this one is tough too. So unexplained thoracic aortic aneurysm. So this is for young people who have an aortic dilation that's unexplained. They do not have any features of heritable thoracic aortic disorder, so they're not syndromic. And they don't have a family history. So if their Z score is 2 to 2.5, the recommendation is they can participate in all competitive sports. But if it's more than 2.5, they shouldn't participate in intense physical exertion or contact sports. So that's a real kind of impressive cut point as to, if your Z score is 2.4, you can play in the NHL. If your Z score is 2.5, you're back to golf and riflery, right? So I think this is really important that these recommendations exist, but they're very non-specific and there's not a lot of nuance to them. And when you're actually discussing these recommendations with patients, there is a lot of nuance, right? So how do we provide real recommendations to people without seeming wishy-washy? And then they go, nobody knows what they're talking about. I'm going to do what I want. So what is the risk of participation? So this was a study of Italian athletes, and of 2,300, they found, and these were kind of competitive athletes, so again, collegiate, national, or international level. They found 17 men, mean age 25, BSA 2.17, so tall men, with aortic diameters more than 40 millimeters. And all of these men, and I think a lot of the language is interesting around this data too, is that they were allowed to continue participation. I think, the idea that it's up to us to allow or not allow to people to participate is an interesting concept, because I think that the data really shows that people will do what they choose to do and they have agency and choice. And so it's really counseling as opposed to allowance. But over an 8-year follow-up, the mean aortic root increased mildly in diameter from 40.9 average mean to 42.9 in these 17 athletes. Non-experienced aortic dissection, 2 had progressive aortic dilation to 50 millimeters, where they were considered for prophylactic aortic root repair. So really the only data we have on ongoing participation, and none of these patients were syndromic, so they didn't have a diagnosis of Marfan syndrome or heritable aortopathy, is that a mild dilation may progress, but your chance of aortic dissection or sudden death is not particularly high until you get to higher dimensions. So how do we incorporate this into counseling? So I just want to stop, and I think I was hoping to leave quite a bit of time for discussion, because I think we really need to talk about how we handle this as a group. But this is Isaiah Austin. So he's 7'1", and he played NCAA basketball. And 5 days before the NBA draft, he was diagnosed with Marfan syndrome. So unfortunately, his dreams were really kind of shattered. He wasn't able to play in the NBA. He was apparently a relatively high draft pick. So he was excluded from play in the States, but then he ended up playing 5 years of professional basketball overseas. So he continued to participate at a really high level, and he did not have an aortic dissection or sudden cardiac death. And, he works in basketball, not as a player, but was able to play 5 years of professional basketball without any negative consequences. And that was his choice. So he made the decision that he would forego insurance and say that he was willing to play and risk it. And he was able to do that. And that was important for his quality of life, right? So I think there are the cautionary tales of people that had sudden cardiac death. And then there are also tales like this, where we've really affected a person's life by giving them exercise restrictions. And, maybe in the end, they weren't rational or reasonable because he was able to play for 5 years without any incident. So in summary, physical activity recommendations of our utmost importance to patients with heritable thoracic aortic disease. So this is something that patients really want to know about, and it's important for them to hear about from their aortopathy providers. The problem is that evidence is scarce. And so we've got a lot of biological plausibility evidence. We have a little bit of evidence in mouse models, but the evidence behind that table and behind our recommendations is actually not particularly robust. I think the other thing is that's important to note is each patient has their own unique risk tolerance, and has an idea of how much each physical activity contributes to their quality of life. And so that has to be factored into the discussion. It's not a one size fits all. And when we do one size fits all, the adherence rates to the recommendations is really quite low. And so, having a conversation with each patient about their values is important. And then again, discussion with HTAD specialists with consistency across providers is necessary. So how do we do this in a way where we're kind of all saying similar things so that patients feel like, even though there's a paucity of data, that we are making recommendations that are consistent. So I'll stop there because I wanted to leave some time for discussion. My thoughts are that in Calgary, for the Calgary Aortic program, I think we probably should develop standardized pamphlets or tools or educational materials that across all specialties we have available to give to patients with some of this evidence in them. And I think we just need to, and having the multidisciplinary clinic is really helpful in that, is increasing communication among providers. So we're kind of all saying the same thing, because I think a consistent message is really important to patients. But I'll stop there and see if there's any questions. And really the goal at this point was to kind of brainstorm as to how we can do this better.
That's excellent, Dr. Keir. Thank you. I have a couple of my own questions, but I'm going to go to Dr. Fedak here. He's got a question here that he writes. Question: use of remote monitoring to get individualized blood pressure responses to exercise and more precise recommendations for patients. And he also writes, sex differences, any research?
So no and no. Yeah. Easy peasy, Paul, to answer that. So I think I think it's a huge opportunity to do remote monitoring in these patients, because there is really no real world data on what exercise does to these patients. So I think it's a huge area. And I think the ability to really scan and see how much physical exertion these patients are doing and what the long-term effect is really, really important. And then we can provide that data to patients because it is quite scarce. So I think that's a huge opportunity. And I think it's an opportunity we have in Calgary because we have the defined clinics and we can follow these patients. The other thing, so sex differences, so no, all of the recommendations are very wishy-washy. Most of the evidence, especially on athletes, is in men, and they exclude women for all of the same reasons that women are excluded from cardiology trial, none which are valid reasons overall. But so there's no evidence actually directly looking at sex differences. All of the resources say, or the recommendations say, if a man, if their aorta is more than 42 millimeters, in a woman, it should be less than 38 millimeters to exercise in unexplained thoracic aortic aneurysm, but again, doesn't take into account body surface area. And I think that's another big problem with a lot of these recommendations is that, there's a big difference between a 5'2" woman with an aortopathy and a 7-foot NBA player, right? And a lot of them are based on absolute aortic root dimensions, which is quite puzzling for people caring for these patients. So no and no, but I think both of those are really important things moving forward. And I think patients need that because, coming to patients with pictures of mouse aortas and telling them what it's going to do to them it doesn't really resonate, right?
Yeah, good points, Michelle. Just want to say, I think this is such an important topic. What a great presentation. And I agree with you. We have a huge opportunity with the talent that we have, in our department to really tackle this. And with our interest in patient-centered care, with our interest in precision health and with our interest in using evidence and getting that evidence, I think we should really think about working together to get this kind of data. We've got some meetings coming up with some providers of remote monitoring tools. So we'll have those meetings and we'll see if we can put something together. Great job.
Yeah, a comment to go along with that, and actually, Dr. Holloway has a comment in that which kind of goes along what I'm going to say, and then we'll go to that. I definitely think we should, amongst the bicuspid clinic, the aortic clinic, come together with some sort of guideline on how we approach patients with this. I actually used that diagram you had in your talk, the last two clinics, to give them something, but I feel. And I could be wrong on this, Dr. Keir, but I think sometimes even across physicians that work together, we might be more stringent or less stringent when we speak to patients. And I get that vibe when I see a patient first or someone else's. So it would be good for us to try and hone down a collective, because it would be good for patients. Dr. Holloway does state here, how do you balance a consistent message between physicians when there is limited evidence and individual nuances? Perhaps it's important to emphasize to patients that they will likely receive slightly different recommendations. And I think that does happen.
Yeah. Yeah, I think that's important. I think I think patients often give us kind of more credit than we should have for how specific our recommendations can be, right? So in that study, I thought it was super interesting that even, a difference of a few kilograms in how much a patient could lift really shattered their confidence. And so I think it's expectation setting is part of it, is that, creating these resources and having these conversations is just being honest with patients and saying, we don't have great evidence, and you will hear maybe slightly different things from different people. And, part of that is factoring in your own values and how important is that activity to you. So I think just letting patients know that this is not written in stone is really important. I think one of the patients I saw in Toronto when I was training, which was just kind of a heartbreaking story, was that he was a Marfan patient in his 50s, and somebody like 20 years ago had told him not to fly because of the pressure changes could cause an aortic dissection. And so he had never been on an airplane, and he was 50 years old. Wow. Because somebody had given him advice that was kind of like a one-off advice 25 years ago. So I think you're right, is that we need to, so consistency is important, but then also saying, we won't be exactly consistent because things are changing, and our recommendations are not based on great evidence. And so, a lot of this is just our best guesses is important. And then also I think revisiting things and saying, what have you been told and what have you been doing are important. Because, a small comment like you shouldn't fly because of pressure changes 30 years ago can have a huge effect on somebody's life if it's not kind of readdressed and rediscussed. And the other thing I think too is that a lot of the patients, and we saw this in congenital heart disease as well, said, okay, we get a lot of don't do this, don't do this, don't do that. But actually, what's the benefit of actually having, and this has been shown in cardiac rehab patients and other populations, it hasn't been shown in this population, but is there a benefit to actually giving them a prescription and saying, here, take your beta blocker, but also on the prescription pad, you should be doing 30 minutes of dynamic physical exercise, however many METs, whatever the VO2 max is, 5 days a week. And so instead of just telling them what they can't do, is there a benefit to telling them what they can do and being really specific about that?
And both Dr. Fedak and Dr. Adams have commented on this, and I was thinking about it as well. Dr. Adams says, I assume return to sports after surgery is okay if it's a valve sparing, to the point that, and I've had this discussion too, and you mentioned it. So you have a connective tissue disorder, Marfan's. I do a valve sparing. The root problem is gone. You still have a connective tissue disorder. You're still dealing with a potential type B dissection, or who knows. At what point can we say, look, the big problem is fixed, you can ease off, and I think direction to patients is variable across physicians in those situations as well.
Yeah, and I think we don't know. So again, there is not really great evidence for sure thoracic aortic or heritable aortic patients, but even patients with, a unexplained aortic aneurysm or a degenerative aortic aneurysm, there isn't great evidence to say when you can return to exercise, how much you can do. The rehab literature for cardiac rehab in patients post aortic dissection or aortic surgery says you don't want to get their systolic blood pressure more than 160 with exercise. But kind of going back to the slides where we showed how much, 3 METs will increase you to 160, right? So are we telling patients with thoracic aortic disease that they should never go above a brisk walk, right? So technically that's the recommendation, but is that reasonable? What's the evidence for that? It's not great. And is that something patients can adhere to, or then we just really fostering inactivity, which can be just as harmful?
To be honest, for degenerative disease, if I resect out your ascending aneurysm, I mean, I don't tell you to go be a bodybuilder, but I other than maintaining good blood pressure control and common sense, I don't push really strong restrictions on my patients. I don't know if that's right, but I don't know.
Yeah, and I think that's the thing too, is that, a lot of our patients will, because I see them after too, right? So they come to us and we say, yep, your big problem is fixed. You can go back to dynamic exercise, avoid the static stuff, no heavy weightlifting. But then they go to cardiac rehab and they're told you can't get your blood pressure above 160 or your heart rate above 80. And so again, it's really confusing for patients. And I think part of it is that we're not acknowledging that we don't know.
Yeah, there's a danger too, I just want to add, of, overdoing it. Like for bicuspid patients, which are mostly what I deal with, if you actually look at their risk of aortic dissection, it's not that high, and they can probably tolerate more exercise than we sometimes. So I find sometimes we over restrict them and we scare them and we say, oh, you're a ticking time bomb and all these things, and it creates a lot of distress for them. So we have to be careful about who the different risk stratifications too. Like a BAV aortopathy, I don't believe is anywhere near what, a Marfan or a true genetic aortopathy is. And we need to give different recommendations.
Yeah, absolutely.
Michelle, this is Mohammed here. My question is, do you differentiate between, when you're giving advice to patients with heritable thoracic aortic disease, which just comprise probably 20% of our patients, as compared to patients who don't have heritable disease?
Yeah, I think so. We should, right? So, for kind of just like Dr. Fidek had just mentioned, for heritable aortopic patients, like if you have Louis-Dietz syndrome or you have vascular Ehlers-Danlos syndrome, or an ACTA2 mutation, we're going to have a much more robust conversation about what your restrictions are. Again, with the caveat that we don't have a lot of great evidence, but I think those patients should be restricted at a higher level than those with a degenerative aneurysm. But again, that's just kind of my feeling, and there isn't really great evidence for that either. And again, when these patients go to cardiac rehab post-op, they tell anybody that's had an aortic surgery, no blood pressure less than 160. But I think, like Dr. Fidek had said, for bicuspid patients, I tend to be much less aggressive with restricting them. For Marfan patients, it depends on what their aortic dimensions are. It depends on whether they've had surgery. And then for the aortopathies with a higher risk of dissection, so Louis-Dietz, ACTA2, we're more aggressive, but there's also the aortopathy. So there's the MYH11 patients, and I have one she's a massage therapist and carries her massage table and basically is doing static exercise all day, and they can dissect it normal aortic root dimensions. So how do you counsel that patient? Do you say, well, you have to lose your livelihood, your aortic root dimension is normal, you have this gene, it's probably pathogenic, we don't know. So there's so much nuance. But I think the evidence is more clear in that patients with a defined heritable aortopathy with a genetic mutation with a high risk of dissection should be counseled more heavily than those with a degenerative aneurysm.
Yeah, and actually, this is actually a bit more clear with syndromic patients, but patients with non-syndromic heritable disease, that's what in my mind, I find it difficult, how would you differentiate in advising them?
Yeah, so I think it does, there is some nuance in the recommendations about family history.
Yeah.
So, we're always happy to see people. I think genetics, the wait list is 2 years, but they're happy to see people as well. And they can kind of give us a better idea. Is this polygenetic or is this a monogenic non-syndromic aortopathy? And so that the hope is that you can get a genetic diagnosis, but you're right, in 50 to 60% of these patients, we don't. We think there's a family history. But so I think the discussion about family history is also important and plays into that. So if there's nobody in the family that's ever had an aortic dissection, then either they're a spontaneous mutation if it's monogenetic, or you think, okay, maybe there is a familial disease, but the risk of dissection is relatively low based on the family history. There is some nuance in some of the recommendations that especially for Marfan patients, that if you've had a family member have an aortic dissection at aortic root dimension less than 50 millimeters, then you should be more aggressive in your recommendations. Again, how many patients do we have actual robust imaging data pre-dissection? Is not terribly high, right? Especially historically. So again, I think the family history is really important, because if you have lots of people that have been dissecting at young ages in the family and they're non-syndromic, then I think you would put them in the Marfan Louise Dietz camp. If not, you're kind of in no man's land.
Yeah.
Does
And
that make sense, Mohammed?
yeah. And also, I see some studies where they restrict the weight lifts according to the size of the aneurysm. If you're 40 to 45, you can lift that much weight. If you're 50 plus, so do you think there's any evidence for that, or the main thing is just basically staying in your limits? And because for somebody who's lifting 40 pounds of weight all their lives, and somebody who has never lifted a 40-pound weight in their ever, it's it's a difference in their activity level.
Yeah, I think that, so again, no evidence. I think that the physiologic studies looking at the increase in blood pressure really do show that if you're doing weightlifting that is lighter, where you can do lots of repetitions and you're not going to exhaustion, then your blood pressure increase is not as high. So that's usually what I tell people, is that there's not a maximum weight. Because I think when everybody wants a weight. When you fill out a disability form for work, they say, how much can the person lift, right? And again, we don't know. But I think that the advice is to, for sure, no Valsalva, no straining, to do light weights where you can do many repetitions, so up to 20 repetitions, and you're stopping well before you get to exhaustion, is kind of the best advice based on the evidence. But you're right, lots of people you shouldn't lift over 25 pounds, you shouldn't lift over 50 pounds. And the evidence for that is not great.
Thank you.
Excellent, Dr. Keir. Great discussion. Excuse me. Great discussion. Oh, I have that same question. Great discussion, everybody. If there's any other things to add to the discussion, please bring it up. Otherwise, I'll end the session. Very important topic that, again, I don't think it gets enough discussion. So this is very helpful, Dr. Keir. Thank you. And I appreciate everybody joining us today. And our next talk will be end of March, and I think that's going to be headed up by the radiology group. So thanks for joining, and we'll see you in March.
Thanks, everybody.